pediatrics. He will be talking on fetal alcohol spectrum disorder, and he doesn't have any financial disclosure. I'm going to tell briefly about Dr. Knopf. It's a really great pleasure for us to have him here. He agreed to do this important subject. He's a professor of pediatrics, pathology, obstetrics and gynecology at the University of Arizona College of Medicine. Giving some background, he did his medical school in University of Alabama School of Medicine, and then his pediatric residency in University of Vermont, and then fellowship in dysmorphology and clinical genetics, University of California. He is diplomat to American Board of Pediatrics and American Board of Medical Genetics. He has many accomplishments. It may take like a lot of time for me to cover all those. I'm going to just say some main things. He's director of clinical genetics here, a section of medical and molecular genetics at university, section chief medical and molecular genetics, and director cytogenetics lab, Department of Pathology here, and also director faculty instructional involvement. He's a member of many, professional societies, including his fellow of American Academy of Pediatrics. He was chairman of dysmorphology subcommittee, American College of Medical Genetics. I'm gonna just list few. He's on board of directors, American Board of Medical Genetics. He has published more than 70, 60 papers and 10 book chapters, and there are some other publications, and they are in all important journals. I was looking at some in the psychiatry field too. One was in American Journal of Psychiatry on second trimester fetal size markers in schizophrenia. And he has been involved with the epidemiology of autism and published in that area too. And he had several grants, and also involved in, doing research on fetal alcohol syndrome. So with all that, I want to invite him and really thank him again. Thank you, Doctor.
Thanks, Dr. Guman. So I want to speak about fetal alcohol spectrum disorders with a concentration on fetal alcohol syndrome. And the discussion I'm going to present to you today is going to be fairly clinical, but I'll try to go over some of the information that I think is particularly important, particularly new, and particularly worthy of you all knowing about. And I tried to give it an appropriate slant toward you all as psychiatrists. As part of my background, I trained in University of California, San Diego, and the person there who is my residency director, or fellowship director, is Ken Jones, who initially described fetal alcohol syndrome back in the early 1970s. And so I had an interest that had started out way back when. And then subsequently have had a couple of grants and currently have a surveillance grant for fetal alcohol syndrome surveillance, and so have maintained quite a good deal of interest in this area. Let's see how good I'm going to be about operating the AV here. So this is a picture of a couple of children with fetal alcohol syndrome, and notice that the first slide said fetal alcohol spectrum disorder, which is in recognition of the fact that when a woman drinks alcohol in pregnancy, there is a spectrum of risk that the child has, with the most serious disorder that would result from that being fetal alcohol syndrome, and these two children exhibiting those facial features that are characteristic of people with fetal alcohol syndrome, which I'll go over in great detail at a point later. But in particular, children have relatively wide spacing of their eyes with small palpebral fissures, and with a relatively smooth philtrum area here, and with a relatively thin upper lip and a lack of that normal Cupid's bow type of appearance. And I'll show you several pictures of other children with this condition. So to let you know, give you a roadmap for where I'm going today, I want to describe the clinical presentation as I've already begun to do. of children with fetal alcohol spectrum disorder with particular emphasis on FAS, or fetal alcohol syndrome. I want to talk about some of the risk factors and the co-occurring conditions, the comorbidities they're sometimes called, of individuals who have FAS or one of those spectrum disorders. And then finally to talk about some interventions that have been suggested and to give you some resources that might be helpful to you when you see families of children who potentially have FASD. First is a little bit of background as why fetal alcohol syndrome might be an issue. CDC studies that have looked at drinking patterns in women find that in women who are 15 to 44, considered the childbearing age, that at least half have drunk alcohol within the last month, and about 15% of those have engaged in moderate or binge drinking. And you can read the rest of the slide here, seeing that 2 to 3% of women who are pregnant actually continue to report binge drinking. It's not an issue for the most part in terms of drinking that women don't understand or don't know that alcohol is a problem. People know that alcohol in pregnancy is a problem and an issue. It's the concern is, of course, that they have the disease of alcoholism or alcohol dependence, which you would certainly know more about than I do. So we all recognize that gulf that sometimes exists between our knowledge and what we do with our knowledge, that is, our behaviors, and this is another demonstration of that. So if you took the 2 to 3% of women reporting binge drinking and you multiplied that times the 4 million children in the U.S. that are born each year, you come up with a number around that 120,000 U.S. newborns that are exposed prenatally to substantial amounts of alcohol. Also, you wouldn't be surprised, I think, to know that alcoholism disrupts families. And if you look at most studies, the children who are identified with FAS, now whether this is truly the full population or not, but those who are identified with FAS frequently are living with non-biological parents. Up to 75% in most studies are not in their biological homes, have been in a foster care situation. Other estimates have suggested that within the foster care system, that over 50% of foster children have some effects from a prenatal alcohol exposure. And again, alcohol being such a prevalent drug in our society, and with the disruption in families, it wouldn't be particularly surprising. And of course, those families of children with who have children with FAS do report increased risks of conflict in their families. To frame the discussion about risk factors and why and how alcohol gets to the baby and the problems that are caused by it, I want to talk about 5 principles of teratology and relate alcohol use to those 5 principles of teratology. And teratology, you probably know, is the study of birth defects or problems, structural abnormalities, or developmental disabilities that occur as a result of a drug or a medication or an environmental agent to which the fetus is exposed during pregnancy. I'm going to go through each of these in turn. I'm going to speak about developmental timing as a particularly important issue. And again, this is not just an issue for alcohol, but this really translates across the spectrum of any kind of drug or medication or environmental agent or disease that a woman might develop during pregnancy. Developmental timing is an important issue to consider in regard to the exposure that the fetus has, the dosage effect, how much that fetus is receiving, the actual susceptibility factors. I'm a geneticist. From a genetic perspective, is an important issue. Of course, that children who have the effects of a prenatal exposure exhibit characteristic patterns of malformation. They don't exhibit heart abnormality in one circumstance for the most part and a limb abnormality for another. They usually have a very predictable type of pattern of malformation as a result of whatever drug or medication they're exposed to. And in the case of alcohol, it's also the case that it's quite predictable and recognizable. And of course, to cause the problem in the fetus, the drug or medication has to get to the fetus, and there has to be actual tissue access. So in regard to developmental timing, remember that after fertilization, that zygote and embryo is migrating and finally implanting in the uterus, and so for those 10 or so days prior to implantation, it's not in contact with the maternal circulation, so an exposure then would not cause birth defects or developmental disabilities because there would not be a connection between the maternal circulation and the embryo or fetus. Then that period of 10 to 60 days after fertilization would represent a period of organogenesis, a very susceptible period for birth defects, and then that day, the time from 60 days to term is a period of growth and differentiation and development. Those organs aren't forming. Remember, they formed in that 10 to 60 days. You know, the heart's very well formed, and I'll actually show you a timeline here. I pulled that out right before I came, a timeline of fetal development so you can get a pictorial representation of just what I'm talking about. So here, in this period, you can see, even helpfully put down here, not susceptible to teratogens, this area here where an exposure causes either death of the embryo or the pregnancy continues, and because of the totipotentiality of embryos, that embryo is going to grow and differentiate and eventually, if all else goes well, be born. And then this period here of organogenesis, where all these organs are forming, which are being pointed out here, and you can see that insults at certain times will produce specific kinds of abnormalities, whereas that fetal period, 60 or thereabouts days to term, is that time where there's growth and differentiation, but not true organogenesis. So there's problems that can happen there, of course, because the brain, as you know, is continuing to form, and there's synapses that are being formed, and there's all kinds of changes that fetus is undergoing. There's general brain growth and numbers of neurons that are growing, and as well as somatic growth. So insults and alcohol use during that time is going to tend to cause problems from a developmental perspective, a developmental disability, as well as growth deficiency or growth retardation. In regard to dosage effects, I think this is something that most of us think of as pretty intuitive. You know, if a little bit's bad, a lot more is a lot worse. And in fact, that tends to be the case with alcohol. But I want to talk to you a bit about some interesting studies that have come out recently that cause us to try to look a little more carefully at just what this means as far as dosage effect in fetal alcohol syndrome. Remember that FAS, this most severe of disorders resulting from alcohol exposure in utero, FAS is associated with severe and regular and heavy drinking throughout pregnancy. And in particular, I point out some facial features to you. It appears that those facial features are the ones that are going to be created by early maternal drinking, because remember, that's where the morphogenesis, the actual development of the fetus, the fetal features as well as the organs is occurring. So you might have a person who could be exposed prenatally to alcohol, not during that early time in gestation, but later on in gestation, and have pretty severe developmental disabilities, but not have the clear facial features and not be identified as having FAS. Those women who drink in moderate levels or binge drink are primarily not at risk for having children with FAS, and those who drink lightly, not either, but would be at risk of having children with what I've labeled here as ARND, which stands for alcohol-related neurodevelopmental disabilities, and I'll have something to say about that later. And I write this here at the bottom of the slide. There's no known safe level of alcohol consumption in pregnancy, so I don't have a recommendation for a level at which a woman can drink and have an assurance of an optimal outcome. At the same time, I'm not a true prohibitionist, and I recognize that throughout history and throughout many cultures that very light drinking or light drinking in pregnancy is something that's been done for quite some time, and those individuals who have done that and those cultures in which that's been prevalent have not seemed to be on any substantial decline. So I don't know that there's not, I'm not here to stand up and say there's absolutely a problem with light drinking, and I'm going to talk about that right now. But I don't know what that level is that one could consider a safe level of consumption. So I want to point out this particular study, which has raised a lot of concern in the media, and which you may have seen. I was on, I don't know, page 2, 3, 4 of our own Arizona Daily Star, and one of our colleagues in the Department of Obstetrics and Gynecology provided a very nice discussion of the issues with this study. But it's a fascinating study, and it comes out of the UK. It's from a Millennium Cohort study, and quickly I'll tell you that it started out with trying to enroll almost 20,000 families of newborns in the UK, 18,000 plus. 85% consented to being surveyed, and so 15-ish thousand or so consented to being surveyed. And at 9 months of age, women were asked about their habits during pregnancy, especially alcohol, medications, smoking, and those kinds of things. And so one sweep of questioning was done at age 9 months of the offspring. One sweep was done at age 3 years, and of course there was attrition in the meantime. And then another sweep of questioning was done at age 5 years, and this has just been EPUB'd. It hasn't been actually published in the Journal of Epidemiology and Community Health. It's EPUB'd ahead of print on October 5th. It should be in print in the next month or so, and raised a tremendous amount of interest by people. What this study found, 11,500 individuals who were questioned, a tremendous undertaking. They categorized women's drinking as either never at all, not a drinker but not in pregnancy, light drinking in pregnancy, which you can see is 1 to 2 drinks per week or per occasion. And then there was a moderate and a heavy alcohol consumption group. And they assessed 2 domains. Well, they assessed behavior and cognition. And behavior was assessed by something called the Strengths and Difficulties Questionnaire. There are 5 behavioral domains in that. The cognitive difficulties were assessed by what's known as the British Abilities Scale, and there were 3 domains that were looked at within that scale. And of interest here, boys and girls of light drinkers had significantly lower overall difficulty scores than those women who did not drink. And then cognitive scores were generally better for boys and girls also in the light drinking group. And that was a source of a lot of dismay and concern of all of us in the community who's trying to limit alcohol-related disabilities. There are some explanations for it, why this study might have found what some have labeled, I think erroneously, I would not want to call it a protective effect, but that's what an epidemiologist might say. That's what would be supported by the epidemiology, a protective effect. I think there's issues with the study that need to continue to be examined. One of the big issues, of course, is that light alcohol consumption is a marker for social advantage in that population. And they tried to control for those issues of social advantage, socioeconomic status, education, and things like that. I don't think they were able to fully accomplish that, but this is of interest, and probably those of you who study alcoholism and alcohol use in adults know that this is not an uncommon thing that one sees in study of alcoholism in adults. That is that problems, that there appears to be a group of people who never drink who are not doing so well as those who drink just a little bit, and those and so there's sort of a U-shaped curve of difficulty, with higher difficulty in never drink populations, more and less difficulty in drinking lightly, and then of course the more one drinks, the more trouble one is apt to find. I will say importantly that behavioral but not necessarily cognitive abnormalities were greater than the other groups for boys and girls in this large study from the UK. So I want to stand up and tell you that I don't know the safe levels of alcohol consumption. I also want to tell you that there is much that we have to learn about dosage effects in alcohol use and the kinds of risks that accrue to offspring of women who drink lightly during pregnancy. Here's a picture of a mom who did not drink lightly during pregnancy and her daughter. This was a cover of the National Geographic some years ago with a mom who's an abstaining alcoholic, and her daughter who has that very characteristically abnormal eyes with a pretty bad strabismus, with an eye that has an ocular muscle problem, and with the characteristic facial features, just to keep in mind what that phenotype looks like. So that's 2 aspects of teratology and 2 aspects of the risk factors that go into what the phenotype is of someone who is exposed to alcohol. That is the developmental timing and the dosage. Genetic susceptibility is another factor, and I'm a little bit behind the times on this next 2 slides, but I'll tell you where I'm in need of some modernization as I talk to you about this particular area of genetic susceptibility. Drugs and medications are eliminated through enzymes. That's just the way we're all set up to work, and these pathways are determined. You know that alcohol is metabolized to acetaldehyde through alcohol dehydrogenases, and there are several different classes of dehydrogenases. Then there are acetaldehyde dehydrogenases that then metabolize the acetaldehyde to acetic acid, and the risk of alcoholism has some strong genetic influences. As some of you probably know, that some of the alcohol dehydrogenase 2 variants, or ADH2 variants, are known to be associated with an increased or decreased risk of alcoholism. Now there's actually a change in terminology. ADH2 is now known as ADH1B, if you look in the literature. But there's been a lot made of the fact that individuals who are of Asian background may have a greater propensity to not be alcoholics because of some abnormalities or some differences, isozymes, if you will, of alcohol dehydrogenase 2 variants, as well as acetaldehyde dehydrogenase variants. And I say here fetal susceptibility factors are largely unknown. I think that continues to be true, but there are some hints that I believe we have now about some beginning information about fetal susceptibility. So here's what I'm talking about when I speak about the different variants of alcohol dehydrogenase. Here's a fast metabolizer here, someone who drinks alcohol, and if they're 60 millimolar, within 2 hours their level is 0. Somewhere out here who's a beta-1 homozygote, takes them quite a long time to metabolize alcohol. They're going to have a long period of inebriation, I guess, for the same amount of alcohol that this person is going to drink. Interestingly, these are people who actually don't have, you might think these are people who would be great. They would drink, they metabolize, they'd be fine, but this rapid metabolism actually tends, it appears, to produce high levels of acetaldehyde in individuals. And acetaldehyde makes you feel pretty crummy, I understand. Gives you a flush reaction, makes you feel a bit nauseated, hot, unpleasant feeling. So these are individuals who actually tend to be less likely to be alcoholics, who metabolize quickly. Now, I said before that I used old terminology. I'm going to apologize to you. The ADH2 now would be more appropriately called ADH1B, and that's the new terminology. But this particular study, I put this slide together some time ago, and I hadn't changed it, and that's where I'm behind the times again last time, but I'll apologize about that. But this allele has been found, at least in one study, in South African women to be more common in control than FAS mothers. And this allele, this 2 allele, is one where women metabolize, or we all metabolize, faster. Again, there's that idea that those who metabolize faster may be less commonly alcoholics because they feel badly when they drink. In looking at other studies of maternal ADH alleles, there's been a variety of things that have been seen. And I just want to point out to you, in case you want to go look up some information yourself, that I located a review, and was just looking at that a moment ago, from 2007 in the American Journal of Obstetrics and Gynecology. It's a human genome review, and the first author is Green, and it's really quite a nice review that looks at alcoholism as well as fetal alcohol syndrome and relates it to a variety of different genetic variants of these alcohol dehydrogenase genes that are present. And what I think that the data support now, as opposed to what I'd said previously, that there's not much known about fetal susceptibility, what they support best is that there is a slow metabolizing allele that's called ADH1B, and then there's a asterisk 1, slow metabolizing allele. And babies who are homozygous for that allele will tend to have slower birth weight, lower head circumference, and lower scores on their intellectual or their early developmental testing than those who have normal alleles. So I think we're beginning to see some information that's coming out, and that would make sense. The ADH1B*1 allele is for slow metabolizing of alcohol, so you would have a long period where there would be alcohol in that woman's system, a longer exposure and higher levels. Patterns of malformation is pretty straightforward. I think that children who have many of you might remember thalidomide being sort of the original teratogen that was out there. Children had limb reduction defects, heart abnormalities, and a variety of very consistent and reproducible abnormalities as a result of this teratogen acting on a very specific pathway. Fetal alcohol syndrome is very recognizable, and it's consistent, and I can recognize FAS. And I think when children come to the clinic, you will often be able to recognize that yourselves. The thing that's difficult, and I suspect that you all are facing, and I certainly face, is that if children have been exposed to alcohol and they don't have fetal alcohol syndrome, that is, they don't have that characteristic facial appearance, they don't have that problem with weight gain and such that is part of the FAS diagnostic criteria, then it's difficult to say for sure exactly what the cause of their problem is, which is what they're usually coming to you for: an intellectual disability, a behavior disorder, a mood disorder, anxiety, conduct problems, and things such as that. So that's what I'm going to speak about for the last half of my discussion this afternoon. Just to point out that as far as patterns of malformation is concerned, this is a mouse model of FAS, and here's an unexposed mouse, and you can see that as opposed to the normal bifrontal diameter here, you have a reduced brain size, a small head, you have small eyes here, you can see the corresponding optic vesicle there, how much bigger it is, and this abnormal philtrum, this abnormal central part of the lip that's so different from the unexposed mouse, very much a part of FAS. And finally, I'll say that the fifth part of teratologic principles is tissue access, and alcohol passes readily into the amniotic fluid compartment, and it's eliminated very slowly from that compartment, so the fetus is exposed for quite some time. I began this talk by saying I was going to speak about fetal alcohol spectrum disorders. Again, a recognition that there's a variety of adverse outcomes that can result, and this particular point here of FASD is that there is a variable set of outcomes from mild to severe. So the classification includes FAS, fetal alcohol syndrome, which I've been talking about primarily and will continue to talk about primarily, partial FAS. And these definitions were actually something that came from an Institute of Medicine publication in 1986 to try to make some sense of alcohol-related birth problems. In the past, we just said somebody had fetal alcohol syndrome or they had fetal alcohol effects, and that was not very specific. I can't say this is a tremendous amount better, but it's a little bit of a step in the right direction to try to recognize that some people will have some features of fetal alcohol syndrome, physical ones, but not the full characteristic syndrome, and they might be called partial FAS. There are individuals who have only neurodevelopmental problems, and there are some who have alcohol-related birth defects. And I'll get into definitions of each of these in just a moment. So for a diagnosis of FAS, one needs to have characteristic facial features, and the common way to define the growth is prenatal or postnatal height or weight below the 10th centile, and then you can see the third domain is central nervous system, and it would either be structural, that is a head circumference less than the 10th centile, microcephaly. Again, not 10th centile for many of us in pediatrics. That's third centile would be a little bit better, but the definition as it has evolved has been 10th centile. Or evidence of CNS abnormalities based on these abnormal features, cognitive, motor, or behavioral kinds of problems. And here's a picture of a schematic of a boy that has some FAS features, or points out the areas, the palpebral fissures being short, sometimes having epicanthal folds, those folds at the inner corners of the eye, the smooth philtrum, this thin upper vermilion, and the smooth philtrum, where those vertical pillars of the philtrum are usually quite distinct. In children with FAS, they're very indistinct. So think about this diagnosis, and you probably have before, but think about how one makes the facial feature criterion. Well, it's a mixture, and it's a mixture of some quantitative things like palpebral fissure length, and you can measure that. There's a whole lot of information out there about how you measure it, what you measure it with, how the person's supposed to be positioned, because there's a lot of issues there. There's also some qualitative kinds of features. It is how smooth is smooth, how thin is thin, and so there's a lot of work that's gone on in trying to recognize that facial appearance and seeing, is that something that really is, you know, the emperor's new clothes in some ways? If somebody just says it, is that what it becomes? Does everybody go, oh yes, I see that too? Or is it really got some objective validity? And I think there's more objective validity than emperor's new clothes to it, but there is some subjectivity that people are continuing to try to take out of the equation. Inter-rater reliability among people like me who've seen lots and lots of children with FAS still remains good, but not as good as I'd like it to be, 85% or so. Pediatricians and other primary care providers, you can see 50% or lower. But for the most part, people in primary care, clinicians who are family practice physicians, pediatricians, are not necessarily making the diagnosis of fetal alcohol syndrome, not having a comfort level with those feature recognition issues. So I'll point out these 4 children of different ethnic backgrounds, and you can see, I think, now beside one another how they sort of do fit. I think you can sort of see very well how thin the upper vermilion is here on all 4 of these children, how there's really no Cupid's bow appearance there, how flat the philtrum appears, how narrow the palpebral fissures are. So you get the idea these are very clear-cut individuals, but if you saw them walking along the street and not in your clinic, I don't think they would stand out in a crowd. Not like the little girl I saw on the airplane yesterday who had Down syndrome, who I saw, and I just looked at her and she's had Down syndrome. It was that quick, you know? It was that diagnosis. It's not that kind of disorder, which makes things a little bit more difficult than diagnoses such as Down syndrome. There are charts for palpebral fissure length. I just wanted to make you aware of that. This is just a gestational age chart for newborns, but there's charts up to age 18 years, and that palpebral fissure length should be measured against those charts. And this is something this particular issue here of using a lip philtrum guide has been a way to try to create objective measure for the lip and philtrum. And you can see the progressive diminution of the height of the upper lip in all these particular photos here. These are 2 photos of Caucasian African American individuals, and then just a cartoon. And you can see from less to most severe over here. And that's a guide that people have tried to use to try to create some objectivity to this. So you think, well, you know, computers are really smart, and a lot of times they're a heck of a lot smarter than me in a lot of things. And so could they be smart enough to figure out who has FAS and who doesn't? The way we've usually done this is by direct anthropometry. By just measuring, you can just measure the face, you can certainly measure the eyes, there's a way to measure the distance between landmarks. But subsequently techniques from both 2D and 3D photography have been developed to try to say, can you identify children with FAS or rule out those who don't have FAS? And although there are some problems with scale, that is, the camera magnifies things as well as positioning, heads up, heads down, heads tilted, those kinds of things. There are some limitations. They're okay. They're pretty good at identifying individuals with FAS. People have also looked at 3D surface imaging using laser scanning, which of course requires lots and lots of equipment. And for the most part, these are good at identifying FAS, not much better than trained clinicians, and quite expensive. But I think there continues to be some role for those particular techniques, especially in research-type studies. So I just want to say this one slide about partial FAS to say that the diagnostic criterion is the prenatal alcohol exposure, some components of the characteristic facial features, and either growth or central nervous system abnormalities. And I'll just leave it at that to say that it continues to be a category that people will sometimes use, but I find it to be quite difficult to operationalize partial FAS in a clinical setting. I think that what becomes even more difficult, and what I know or believe that you all are facing based on my discussions with some of you, is this issue of alcohol-related neurodevelopmental disorder. So they don't have the facial features. They don't have FAS. They don't look like those kids that I just showed you. They aren't small and growing poorly, but they either have a small head size or what you have here, and you can read this pattern of behavioral, etc., abnormalities, inconsistent with the developmental level and not explained by family background or environment alone. Well, I don't have to tell you all who've seen children that, a lot of children, in some cases some more than I have, that pathology, that mental health issues, that neurocognitive and neurodevelopmental problems occur in the offspring of children who don't have a family background that would tend to predispose them to that, and it can't be explained on the environment alone. So this becomes a very difficult issue to operationalize also. And I'll get to that whole issue in a minute, which is parent brings child to you and says, do they have a fetal alcohol spectrum disorder? And you look at them and you feel confident that they don't have FAS based on the fact that they're normally grown, and you're able to look at them and have a confidence level that they don't have those facial features. How confident can you be to say, this child in front of me has ARND, an alcohol-related neurodevelopmental disorder? And I will get to that in the 2 or 3 or 4 slides, because I think that's probably one of the more important issues for you all who are trying to be a good evaluator, advocate for the child, and advocate for that child within systems of care that are out there for them. You know, in addition to problems such as growth problems that children and adults with FAS have, and basic intellectual disabilities, there's a variety of other kinds of things that they're at long-term risk for. All kinds of mental health disorders, I'll get to you that in a moment, adjustment disorders and cognitive problems. And one thing that's very clear is that people with FAS are far overrepresented in psychiatric and juvenile correction samples. So they tend to be referred to you all. They tend to be people who get into trouble from the standpoint of their behavior and their judgment, and they end up in systems of care that are overall problematic for them. I want to paint in 2 slides or so a little bit of a picture of how children's neurobehavioral and neurocognitive development goes, these children who have FAS. So as newborns, very early on, the offspring of women who drink heavily compared to those who don't have these problems that I describe here: increased activity, decreased habituation, and poor sleep. So you know, many of you might know what habituation is, but I'll explain it a bit for those who don't. Habituation in an infant, at least as a newborn, if you do a Brazelton exam on them, is you have the infant lying there quietly in a normal state, and you ring a bell and they startle, and then they, over time, or create some kind of disturbance, and over time, a normal newborn will learn to accommodate, to habituate to that particular stimulus. They learned how to tune it out over time. Kids who've been exposed to a lot of alcohol don't habituate. They continue to be stimulated at the same levels or similar levels over time. And so you can see how, as they get older, and get into early childhood or into childhood, that child who is sitting in the classroom, who might notice that there's something out the window, would eventually be able to habituate to the train, perhaps that's outside and making noise, to the cars that are going by, if you're a normal individual. But if you can't habituate, if you aren't able to tune out certain stimuli, then you're going to end up being quite distractible, and you're going to have difficulties with sustained attention and to be appropriately emotionally reactive. And so I think that's the continuum that's seen from newborns into childhood. For your own profession, I would say that it's been found that children of moms who drink heavily are more likely to report depressive symptoms than moms who didn't drink. It's still not very high. So in one study, 20% to 1%, or 40% to 19%. So there's a, at least a 2-fold and sometimes a much greater than 2-fold difference in offspring of women who drink versus those who don't drink. But remember, as I know you do, that both genetic and maternal infant factors can influence that risk, meaning that what you already know, that people who grow up in a household where there's a parent who has depression will have both environmental reasons as well as genetic reasons, perhaps have an increased risk for depression. And in middle childhood, I'll point out that mood disorders and as well as inattention and impulsivity continue to be particularly problematic issues for these children. And there's a huge debate in the child psychiatry FAS community regarding attention deficit disorder and whether children with FAS have an increased risk for attention deficit disorder as it's defined by DSM-4 and soon to be 5, I guess. And many will be diagnosed with that condition, especially if it's parent-reported. There's a high percentage that are diagnosed with a condition, but through professional evaluation, those who are used to and commonly evaluating children with alcohol exposure will say, actually, and I don't understand this well, you would understand the literature, I'll have to point you to it, that those children who have attention problems related to alcohol exposure have a different type of attentional issues than those who aren't. And I'll just have to point you to the vast literature. Probably the person that's written the most about that is Claire Coles, C-O-L-E-S, who is at Emory University. And in adolescence and young adulthood, you can see the kinds of problems that continue to haunt children with alcohol exposure. So, how do you diagnose ARND? Well, I don't have a good answer for you there. There's no strict diagnostic criteria that uses specific behavioral or cognitive profiles. So it's not possible for one to, at least as I see it and as I think most psychologists, even those with the greatest experience in alcohol-related developmental disabilities, to have two children, each of whom has, let's say, a mood disorder plus anxiety, or whatever their psychopathology is, and to be blinded to their prenatal status and to pick out, based on their cognitive, developmental, behavioral profile, those who have the problems related to alcohol exposure versus those who have their neurodevelopmental problems related to who knows what else, all those kinds of idiopathic reasons that people have those disorders. So I don't think it's possible, or I wouldn't foist on you the burden of being able to look at those children and to divine those children who truly have an alcohol-related problem versus the problems that come from goodness knows where they come from, or in the case of many children who would come to you, children who come from backgrounds where the parents are not necessarily well-adjusted themselves, the parents who themselves may have depression, who certainly have a history of substance abuse, alcoholism, alcohol dependence, and perhaps other kinds of substance abuse kinds of issues, and all the genetic loading that is involved in those particular individuals, and say, yes, 80% of their problem is related to alcohol and 20% is related to the fact that mom and dad each have an IQ of 70, and then of course you have to throw in the idea that many of those children have been reared in chaotic rearing environments when they're younger before they enter perhaps a foster care system, and I think it is just not possible to disentangle the alcohol-caused disability from the other-caused disability. So you're the ones that are knowledgeable about the co-occurring conditions, and in designing a behavioral or pharmacologic intervention, the co-occurring conditions are where it's at as far as I'm concerned. And I'm not going to go into any detail here. I'm just going to leave this slide in your handout for you to realize there's a really nice systematic review by Peden from the British Medical Council of Pediatrics in 2009, looking at interventions for children with FAS. So looking at 2 randomized controlled trials of pharmacologic intervention shows some benefits of short-term stimulant medication. There is really a paucity of good interventional information out there on fetal alcohol syndrome. There's been some educational interventions, and again, this is out of well over 100 different studies they looked at. They found 12 studies of interventions that had some validity and thought might be worth considering. you can see that there's some educational interventions and some social, behavioral, and communication interventions that have showed some benefit, but there's much more that's needed in regard to the types of interventions that are going to be helpful. And so I try to break it down a little bit more straightforwardly and simply, and I don't think that this advice is any different from what you would see for other children with developmental disabilities or attention problems. And you'll see here things like establishing routines, giving short and simple instructions, writing it down and sending them home, make the directions specific, repeat those tasks multiple times, and then supervise children. These are all very intuitive kinds of things, but I think that they're worth remembering and worth reiterating to families when they ask what can be done for their child. And I won't really go into this set of issues. The main reason I put this slide in is for this, to say here is one component of FASD treatment, psychological and psychiatric treatment. It's not the only one, and one of the things that's helped me most over time is to give up my feeling that I have to be able to go in and really make a global difference for that child. You have your area of expertise and ability to intervene. The educational, vocational system has their area. There are other medical issues, and parents have their own area. And saying what it is that you can do is important, but recognizing that there has to be a broader approach from a variety of different caregivers, both inside and outside the home, is particularly important. Last couple of things to say. Prevention. Women can stop drinking if they're capable of becoming pregnant, or women who are drinking can have effective birth control and recognize that now, during a period when they are non-abstinent alcoholics, is a time not to have children. And so either of those strategies would be effective. And finally, I'll leave you with this information. One of the people who's written most about fetal alcohol syndrome is Ann Streiskuth. She's in Seattle. She was a part of the group that originally recognized FAS in the early 70s, and she has a guide. You can point families to that. The website, National Organization on Fetal Alcohol Syndrome, NOFAS, has a wide variety of references there, fact sheets, resources, support groups that you can put people in touch with. And I think that's another thing that you can do is you can download their handouts. You can provide those resources to families. And then here in Tucson, there's an organization called FAS Arizona that I give you the website for, and they also have many of those same materials that you can download and use. And if you see someone has a child who's been exposed to alcohol and their problems may be alcohol-related neurodevelopmental disabilities, you can say, I think here are some of the resources that are out there. Please try to access these, see how they work. I will treat this child's mental health issues in the best way I know how, and you will have co-occurring diagnoses or diagnoses for which there are clear treatment goals and clear treatment pathways, and you can follow those and look toward school system and parents to implement the other kinds of strategies. And hopefully everybody will turn out happy and healthy, or at least optimally developing and doing well. Yes, question?
Is there actually an experimental animal model to support or justify diagnosis like ARND?
There